"Get away from my patient. You don't have the authority to touch him." Dr. Dorian Mercer's voice cut through the trauma bay like a blade. Dr. Corinne Lawson didn't answer. She grabbed the Reboa kit, threaded the balloon catheter into a dying man's aorta with bare hands and no ultrasound, and brought his heart back from a flatline that had lasted nearly a minute. Then the door opened. A Marine general walked in, looked straight at her, and said 4 words. No one in that room had ever heard the legend of Kandahar. She had saved a man's life. Now the hospital wanted to end her career for it. And before this night was over, everyone in that building would have to decide which one of them was actually dangerous. Welcome back to Mystic Chapters, the channel where every story hides a lesson worth staying for. If you've ever watched someone get punished for doing the right thing, stay with this one till the end. And if you're new here, hit that subscribe button. New chapters unfold every week, and you won't want to miss what's coming next. St. Gabriel Medical Center had built its reputation on 2 things: an unbroken record of trauma center accreditation, and a hierarchy so rigid it might as well have been carved into the walls. The Level 1 trauma designation meant the most critical cases in Chicago came through those doors. Gunshot wounds, multi-vehicle collisions, falls from height, industrial crush injuries. It also meant the physicians who worked those floors had fought hard for their positions and did not take kindly to anyone who threatened the order they had spent careers constructing. At the center of that order, unmoved for more than 2 decades, stood Dr. Dorian Mercer. He was not a careless doctor. That was the important thing to understand about him. He was not incompetent, not negligent in the way that made lawsuits easy. He was precise, credentialed, and well-connected in every academic circle that mattered in this city. He had published, lectured, sat on committees, and cultivated the kind of institutional influence that made department heads think twice before crossing him. What he was beneath all of that was a man who had confused the map for the territory. He believed that the path he had taken, the right schools, the right residencies, the right publications, was the only legitimate path. Anyone who arrived differently was, by definition, arriving wrong. Which was why, when the hospital announced the hiring of Dr. Corinne Lawson, Mercer did not bother to read past the first page of her file. He read enough to see that her surgical training had been completed under military auspices, that the bulk of her trauma experience came from forward operating bases and combat support hospitals in Afghanistan, and that her publication record was essentially non-existent by academic medicine standards. He stopped there. He had already made his determination before she walked through the door. Her first day, staff orientation, was less an introduction than a performance, Mercer establishing, in front of an audience, exactly where she stood. He called her a tent doctor. He said it with the casual precision of someone who had rehearsed the phrase until it no longer sounded cruel, just factual. He implied the hospital had hired her for optics, not ability, that her battlefield skills were a different discipline entirely, suited to the chaos of war zones but ill-fitted to the structured environment of a modern urban trauma center. A few of the residents laughed. Others looked at their shoes. The joke landed cleanly and Mercer moved on to other business. Karen said nothing. She opened the worn military trauma bag she had carried through 3 deployments and began arranging its contents methodically on the workstation she'd been assigned. It was not passivity. Anyone who had spent enough time in high-stakes environments would have recognized the behavior for what it was. She was orienting herself, taking inventory, deciding what mattered and what didn't. Mercer's words fell into the second category, and her silence in response unsettled him far more than any argument would have. Dr. Leah Navarro stood at the edge of the room during that orientation and did not laugh. She was in her 3rd year of residency and had learned a great deal under Mercer, some of it medicine, more of it the mechanics of institutional survival. She had made a small mistake 18 months earlier, a misread imaging result on a night shift, and Mercer had named her in front of the full department at the next morning's briefing, not to teach and to establish. She still felt the shape of that moment when she moved through certain hallways of the hospital. She watched Karen arrange her equipment and said nothing, but she filed it. The silence, the steadiness, the absence of performance. She had learned to pay attention to things Mercer dismissed. The first real test came 4 days after Karen's arrival. A 23-year-old was brought in by ambulance following a minor car accident. Low speed, minimal vehicle damage. the kind of call that rarely escalated. The resident assigned to him, a second year named Dr. Travis Holt, assessed the patient's rapid breathing and agitation as a panic response common in young men who had never been in an accident before. He ordered a sedative and moved to the next bay. Karen was passing through reviewing a chart and she stopped. She watched the patient for 11 seconds. His trachea deviated slightly to the left, his neck veins distended, his oxygen numbers drifting downward in a way that didn't match anxiety. She put down the chart, told the nurse to pull the crash cart closer, and decompressed the patient's chest with a needle before the next resident had finished writing his note. The tension pneumothorax released with an audible hiss. The patient's oxygen climbed back to normal within 60 seconds. Without the intervention, he would have gone into cardiac arrest in under 3 minutes. Mercer called Karen into his office before the end of her shift. The door was closed, but the glass panel beside it meant anyone walking past could see the two of them, which was, she suspected, intentional. He told her she had acted outside the chain of command, that Dr. Holt was the attending physician of record on that patient and that performing a procedure without clearing it through the supervising physician was a violation of St. Gabriel's clinical protocol, regardless of the outcome. She was still within her probationary evaluation period. One more incident of unilateral action could result in suspension of her surgical privileges. Karen looked at him without expression and said that a patient intention, pneumothorax, could not wait for a chain of command to convene over who had permission to save him. Mercer told her that was exactly the kind of cowboy thinking that made military-trained physicians difficult to integrate into civilian practice. She thanked him for his time and left his office. The conflict between them was no longer theoretical. It had taken its shape, and both of them knew it. The night of November 27th arrived without warning, in the way that Chicago winter storms often do. The forecast had predicted flurries, and by 10 o'clock a full ice storm had paralyzed 3 major expressways. St. Gabriel's Trauma Bay went from manageable to overwhelmed in under 40 minutes. Fractures, concussions, lacerations, a man who had walked into the side of a spinning truck while trying to help a stranded motorist. Every bay was occupied. 2 were running simultaneous resuscitations. At 11:14, Leah took a radio call from the paramedic unit on Expressway 90. A black SUV had been driven off an overpass by a commercial truck that had lost its brakes on the ice. The driver was male, estimated to be in his early to mid-50s, well-built, no identification on his person. He had sustained chest, abdominal, and pelvic trauma consistent with a high-speed rollover, followed by a significant fall. 2 units of packed red blood cells had already been administered in the field and had produced no measurable improvement. His blood pressure was 60/40. His heart rate was 142. Dr. Julian Keene, the department's vascular surgeon, was 3 hours into an emergency aortic repair in operating room 2 and could not be reached for at least 30 minutes. Mercer declared himself the commanding physician and ordered Bay 4 prepared. In the time it took the assigned residents to locate the correct supply carts, Karen had already staged the rapid infuser, the thoracostomy tray, the portable ultrasound, and the Reboa kit in the order she expected to need them. One of the residents started to ask who had authorized the Reboa setup, and she told him to get a second large-bore IV started in the patient's right antecubital and stop asking questions. The paramedics brought the man in at 11:21. He was gray, his systolic pressure now undetectable by the transport cuff, his abdomen distended and rigid. Karen placed both hands on his pelvis before anyone had finished transferring him to the bay table. She pressed inward with controlled pressure, testing stability, and felt what she had suspected from the moment she heard the mechanism of injury described over the radio. The entire pelvic ring shifted under her hands like a book being opened, both halves rotating outward, the posterior ligaments completely disrupted. In a trauma patient already hemorrhaging, an open book pelvic fracture was not a finding. It was a countdown. She looked up at Mercer and told him clearly that the patient was exsanguinating into his retroperitoneal space, that the pelvic ring was fully unstable, and that intubating him now with the vasodilatory effect of induction agents would drive his blood pressure to a level from which it would not return. They needed a pelvic binder applied immediately. A massive transfusion protocol escalated, and a decision about aortic occlusion within the next few minutes if his pressure did not respond. Mercer told her to step back from the table. His voice was flat, certain. He had heard the concern and evaluated it against something that had nothing to do with medicine. The fact that Karen had been in his department for less than 2 weeks. The fact that he had already spoken to her once about insubordination. The fact that she was stating her assessment with a confidence that, in front of 4 residents, felt like a direct challenge to his authority. He told the anesthesia resident to proceed with rapid sequence intubation and told Karen a second time to move away from the patient. The propofol and succinylcholine went in at 11:24. The blood pressure, which had barely been registering, vanished entirely from the monitor within 40 seconds. The cardiac rhythm shifted irregular, wide, complex, deteriorating, and then the waveform on the monitor went flat. The man's heart had stopped. Mercer called for chest compressions, for the defibrillator, for epinephrine. The residents responded instantly, one climbing onto the step stool to begin CPR, another drawing medications, a third calling out time intervals. It looked like a resuscitation. It was not. Karen could see it in the ultrasound image she had captured 30 seconds before the arrest. The heart already squeezed dry by hemorrhage, being asked to pump a circulatory system that no longer had enough volume to sustain a rhythm. Compressions would circulate what was left. They would not fix what was missing. She looked at the Reboa kit on the supply cart. The procedure involved inserting a catheter through the femoral artery and advancing a balloon up into the aorta, then inflating it to occlude blood flow below the level of hemorrhage, forcing what remained of the patient's circulating volume back toward his heart and brain, and buying enough time to get him to an operating room. She had performed the procedure 17 times in the field, twice without imaging, once in conditions that would have been unimaginable to anyone who had only ever worked inside a hospital. Her endovascular privileges at St. Gabriel were pending committee review. She had submitted the application 8 days ago. Mercer turned from the resuscitation and told her directly that if she touched that kit, he would have her suspended before the patient left the bay. Karen looked at the monitor. The line was flat and had been for 41 seconds. She thought briefly and without sentiment about a young Marine corporal she had not been able to reach in time in the Arghandab River Valley, not because she lacked the skill, but because she had waited 11 minutes for a command decision that should have taken 2. She had carried that decision or the absence of it for 7 years. She walked to the supply cart. "Stop compressions," she said, loudly enough that everyone in the bay could hear her. "We are pumping a body with no blood left to pump." She picked up the Reboa kit. Mercer reached for the wall phone and called the security desk. He stepped directly in front of the bay table, not to treat the patient, but to block her. He positioned himself between Karen and the man on the table with the deliberate physicality of someone who had decided that the conversation about authority was more urgent than the flat line on the monitor behind him. He told her again that she had no endovascular privileges at St. Gabriel, that performing the procedure would constitute an unauthorized intervention on a patient under his care, and that he would have her arrested for criminal endangerment before she reached the femoral artery. His voice was controlled. He was not shouting. That somehow made it worse. Karen looked past him at the monitor. 49 seconds since the last detectable cardiac activity. She set the kit on the edge of the table and spoke to the room rather than to Mercer, specifically addressing the residents, the nurses, the 2 security guards who had just appeared in the bay doorway. She said the patient had no circulating volume sufficient to respond to compressions or vasopressors. She said the source of hemorrhage was the disrupted pelvic ring, and that the only intervention with any probability of reversing his arrest was temporary aortic occlusion. She said all of this without raising her voice, in the same register she might use to read a lab result, because clarity was what the room needed and she knew it. Leah stood at the foot of the table and looked at the portable ultrasound screen, which still displayed the last image Karen had captured before the arrest. The heart barely moving, the abdominal cavity filling with fluid. She had seen enough resuscitations to read that image. She had also seen enough of Mercer to know what happened to residents who contradicted him publicly. She did not move to stop Karen. The ultrasound machine chose that moment to lose its signal entirely. The hospital's imaging network, already strained by the volume of simultaneous cases across the building, dropped the connection and left the screen dark. Karen absorbed this without comment. She had placed Reboa catheters without imaging before. The anatomy did not change. What changed was the margin for error, and the margin here was already gone. So the variable barely registered. She palpated the right femoral artery with 2 fingers, found the pulse, faint, barely present but there, and positioned the needle. Mercer told her one more time to stop. She made the puncture. The flash of dark blood into the syringe confirmed arterial access, and she threaded the wire into the lumen with the practiced economy of someone who had done this in worse conditions than a well-lit trauma bay in a fully equipped hospital. The security guards looked at Mercer. Mercer looked at Karen. No one moved to pull her away. One of the guards, a heavy-set man in his 40s who had worked the hospital's overnight shift for 11 years, later told a colleague that he had stood there doing the math. If he grabbed the doctor and the patient died, he would have to live with that. The math came out the same way every time he ran it. So he stayed where he was. Karen advanced the catheter, tracking the wire by feel and by the anatomical landmarks she had memorized, not from a textbook, but from the specific, irreplaceable knowledge of having done this when the stakes were absolute. The balloon had to sit in the 3rd zone of the aorta, below the renal arteries, above the aortic bifurcation, directly above the hemorrhage field. Too high and she would ischemize the kidneys. Too low and the occlusion would accomplish nothing. She fixed the depth, confirmed positioning by the resistance in the catheter shaft, and began to inflate. The room was quiet enough that the mechanical click of the inflation syringe was audible. 3 seconds passed with the monitor still flat. Mercer, who had not moved from his position near the table, reached out to take Karen's arm. Then the monitor produced a single narrow deflection, not a full complex, barely a blip, and everyone's eyes went to the screen before their bodies caught up with the impulse. A second deflection followed, wider, then a third, and the waveform began to organize itself into something recognizable. The blood pressure cuff, which had been cycling on the patient's left arm, returned a reading 65/38, then 2 minutes later, 81/50, then 94/61. The man's chest was rising. His color, which had been the specific gray of profound shock, had begun to shift toward something less final. The residents stood at their stations and did not speak. The nurse who had been recording the resuscitation time stopped her pen mid-notation and looked at the monitor for a long moment before continuing. Mercer stepped back from the table. He did not say anything for several seconds. Then he told the nearest resident that the result was inconclusive, that a transient pressure response during resuscitation did not validate the procedure, and that this situation would be reviewed formally. He turned toward the bay entrance and told the security guards that Dr. Lawson should be escorted from the department as soon as the immediate clinical situation was stabilized. His voice had regained its composure, but something underneath it had shifted. The particular quality of a man reassembling an argument he knows has already been undermined. The bay door opened before the guards could respond. 4 men in military utility uniforms entered in a configuration that was not quite formation, but carried the same implication: disciplined, purposeful, positioned around a 5th man who was taller than the rest and moved through the crowded bay, with the specific authority of someone who had never once needed to announce himself. Brigadier General Everett, Rourke, United States Marine Corps, stopped at the foot of the bay table and looked at the patient. Whatever else was happening in that room stopped. Rourke looked at the monitors, at the catheter line running from the patient's groin to the inflation syringe in Karen's hand, at the blood pressure waveform moving steadily across the screen. He asked, without looking up, who had placed the balloon. His voice carried the same flatness as Karen's, someone accustomed to receiving information rather than performing for an audience. Mercer answered first. He said that Dr. Lawson had performed an unauthorized endovascular procedure in direct violation of her clinical privileges and over his explicit objection, and that he intended to file a formal complaint with the medical board. He said it clearly, with the confidence of a man reciting a prepared statement, which was essentially what it was. Rourke looked at Karen. Then he took in the details the way soldiers and surgeons both learned to, quickly, without appearing to, storing information before committing to interpretation. The silver at her temples, the particular stillness of her posture, the thin scar that ran along the lateral aspect of her right wrist, the kind of mark left not by a scalpel, but by wire or shrapnel, moving fast through inadequate cover, He said her name, her rank, and the rank she had held the last time he had seen her work. Commander Lawson. The residents looked at each other. Leah looked at Karen. Karen kept her eyes on the monitor and did not react. But her hand on the inflation syringe was very still. Rourke turned to the room and said what he knew, because the situation required it, and he was not a man who withheld necessary information. He told them that Karen had served as the primary surgeon for a forward resuscitative surgical team attached to Marine Raider operations in Helmand and Kandahar provinces. He told them that during a coordinated mortar attack on their forward position, with their surgical facility compromised and evacuation unavailable, she had operated continuously for 17 hours on casualties who would not have survived transport. He said that the men who had come home because of what she did that night had a name for her, and that it had nothing to do with any hospital credential or committee approval. Then he looked directly at Mercer and said it. You called her a tent doctor. My Marines called her the Legend of Kandahar. The room absorbed it. Mercer's expression did not change, but something around his eyes did. A recalibration occurring in real time. The mind catching up to a situation it had fundamentally misread. Rourke then identified the man on the table. His name was Samuel Vance, a retired Army colonel who had been working as a senior security consultant for the Department of Defense. He had been traveling without identification as a standard precaution for individuals in his advisory role. There was nothing unusual in that, only the unfortunate collision of protocol and circumstance on an icy overpass at 11 o'clock on a November night. He was not a mystery. He was simply a man who was nearly dead, and who was slightly less dead than he had been 6 minutes ago because of what Karen had done. The clinical reality reasserted itself almost immediately, because that is the nature of trauma. The story never waits. Karen told the room what she had not said aloud yet. The balloon could not stay inflated. Zone 3. Occlusion bought time by preventing further hemorrhage into the pelvis, but it also cut perfusion to the lower extremities and created an ischemic clock on everything below the level of occlusion. She estimated they had a window of 25 to 30 minutes before the tissue injury from occlusion began compounding the injury from hemorrhage. They needed the OR before that window closed, and they needed a vascular surgeon who could manage the pelvic arterial reconstruction while she managed the balloon. Keene arrived at a near run, still in his OR clogs, alerted by the nursing supervisor. He reviewed the monitor readings, examined the catheter position by feel, and looked at Karen with an expression that had moved past surprise into something closer to professional assessment. He said the placement was accurate, balloon in the correct anatomical zone, inflation pressure appropriate, hemodynamic response consistent with effective occlusion. He said, as a direct statement rather than a compliment, that he would not have expected that level of precision from anyone working without fluoroscopic guidance on a patient in active arrest. He ordered immediate transfer to OR3 and called for the trauma surgery team. Mercer stepped into the hallway and told Keene that Karen had violated her privileges and should not be permitted to accompany the patient further. He said it with the formal precision of a man filing a record, which was exactly what he was doing, establishing a narrative before the facts could arrange themselves into a different shape. Keene looked at him for a moment and said that Karen was the only person in the building who knew the exact inflation time, the catheter depth, and the patient's hemodynamic response curve since balloon placement, and that he needed that information continuously during the repair. He was not asking for permission. He told Karen to scrub in. Rourke added nothing. He simply did not move from his position in the doorway, and Mercer did not push the point further. As the Bay team prepared to move Vance, Karen gathered the inflation syringe and walked alongside the gurney. She heard Mercer's voice behind her, level and certain, aimed at her back. He said that regardless of the outcome in the operating room, her position at St. Gabriel was finished. She did not turn around. The surgery lasted 7 hours and 20 minutes. Keene repaired the disrupted iliac artery, reconstructed the posterior pelvic ring with external fixation, and controlled 11 separate bleeding points identified only after the retroperitoneal space was opened and evacuated. Karen managed the balloon in staged deflation increments, monitoring the hemodynamic response at each step to prevent the sudden pressure drop that could accompany full reperfusion after prolonged occlusion. Vance's pressure destabilized twice. once at the 2-hour mark during the iliac repair, once near the end when a small vessel that had appeared controlled began to bleed again. Both times Karen caught it on the monitor before the anesthesiologist called it. Both times the response was immediate. At 6:41 in the morning, Samuel Vance was moved to the surgical intensive care unit in critical but stable condition. Both legs had measurable pulses. His kidneys were producing urine. His brain, deprived of adequate perfusion for under 60 seconds before the reboa restored flow, showed no indication of anoxic injury. Karen walked out of the operating room and found a hospital administrator waiting in the corridor with an envelope and a request, delivered with genuine discomfort, but delivered nonetheless, that she surrender her badge and leave the premises pending a formal review. Mercer had filed his complaint at 4 in the morning from his office while Karen was still in surgery. The formal review convened 3 days later in the hospital's third-floor conference room, chosen, Karen suspected, because it was large enough to accommodate a board quorum but removed enough from the clinical floors that the proceedings would feel administrative rather than medical. She arrived alone. She had been advised by 2 separate colleagues to bring an attorney. And she had considered it and decided against it, not out of stubbornness, but because she understood that the presence of legal counsel would reframe the hearing in a way that served Mercer's narrative more than her own. He wanted this to look like a liability matter. She wanted it to look like what it was. Mercer sat at one end of the long table with the composure of a man on familiar ground, which this was. He had served on this board's clinical standards subcommittee for 9 years, and had sat in this specific room for dozens of peer reviews, most of them involving physicians with far less institutional standing than himself. He had prepared a written summary of the incident that ran to 11 pages, organized carefully. The procedural violations first, the question of patient safety. Second, the broader argument about clinical culture third. He was not wrong that the document was persuasive. It was the kind of persuasive that works when the reader has no other information. Edwin Carver, the hospital's executive director, opened the proceedings by noting that St. Gabriel's Level 1 trauma designation was contingent on strict adherence to credentialing protocols, and that any finding that unauthorized procedures had been performed on a patient in this facility, regardless of outcome, represented a potential accreditation risk that the board was obligated to take seriously. He said this without particular hostility toward Karen. He said it the way administrators say things when they are genuinely frightened and are using formal language to manage that fear. Mercer presented his account. He described Karen as a physician who had substituted battlefield instinct for institutional protocol, who had disregarded a direct order from the supervising attending, and who had performed an invasive endovascular procedure on a critically ill patient without the required privileges or authorization. He said that the fact of the patient's survival was not the relevant variable, that the question before the board was whether St. Gabriel could function as an institution, if individual physicians were permitted to override the chain of command based on their own assessment of urgency. He framed it well. He had been framing arguments in rooms like this one for a long time. When it was Karen's turn, the board chair asked whether she wished to call on General Rourke, whose office had already been in contact with the hospital's administration, and whose interest in the proceedings was well understood by everyone at the table. Karen said no. She said that her military service and her relationships with senior military personnel were not relevant to the question of whether her clinical decision had been appropriate, and that if the board reached its conclusion based on outside influence rather than medical evidence, the conclusion would be wrong regardless of which direction it fell. She asked that the decision be made on the facts of the case as they existed in that trauma bay on the night of November 27th. The board chair asked her to present those facts. Leah Navarro was not on the witness list. She had been identified in Mercer's written summary as a resident who had been present in Bay 4, and the board had assumed she would corroborate the attending physician's account, as residents in these situations almost universally did. When she entered the conference room and requested permission to submit evidence, Carver looked at Mercer and Mercer looked at Leah, with an expression that had not yet settled into anger because it had not yet fully processed what was happening. Leah placed a tablet on the table and explained that Bay 4's audio monitoring system, installed 18 months earlier as part of a patient safety initiative and not widely known among senior staff, had been recording continuously on the night in question. She said she had pulled the timestamp log after the incident and had retained a copy of the relevant segment. She said she understood that submitting it without prior authorization from department leadership was outside normal protocol. Then she looked at the board and said that she had watched someone follow normal protocol on that table, and she had watched what it produced. And she was not willing to be silent about the rest of it. It was the same calculation she had been running since the night of November 27th. The same math she had done standing at the foot of that bay table, watching a man's chest rise again because someone had refused to wait for permission. 18 months ago, Mercer had put her name in front of a room full of colleagues for a mistake she had already corrected. She had said nothing then. This time she had evidence, and this time the stakes were not her dignity but a man's life and a physician's career. And Leah had decided that silence had already cost this department enough. The recording was played in full. The board heard Karen's voice measured and clear, describing the open book pelvic fracture and the risk of hemodynamic collapse following induction, delivered not in the middle of the resuscitation, not as a reaction to crisis, but before the intubation, while the patient still had a pressure and a chance. They heard Mercer's response, which was not a clinical counter-argument. They heard the subsequent sequence of events exactly as it had occurred: the intubation, the arrest, the flatline, the reboa placement, the return of cardiac activity. The recording was 11 minutes and 43 seconds long, and the room was completely quiet for all of it. The hemodynamic data from Bay 4's monitoring system was submitted, alongside the audio time-stamped waveform record showing that the patient's cardiac output had been 0 for 58 seconds before the balloon inflation, and that the first measurable pressure response had appeared within 90 seconds of occlusion. The data did not require interpretation. It was a sequence. It said what it said. Keene provided his assessment in writing, which the board chair read into the record, that the balloon had been positioned accurately in zone 3 of the descending aorta, without fluoroscopic guidance, that the inflation pressure and timing were appropriate, and that in his professional opinion, the intervention had been the sole factor responsible for the patient's survival to the operating room. He added in a sentence that had clearly been considered carefully before it was written, that placing a reboa catheter correctly on a patient in cardiac arrest without imaging was something he could not say with certainty he would have accomplished. Under those same conditions, the altered incident report surfaced through the hospital's information technology department, which had been asked by the board to verify the document metadata as part of the standard review process. The original file showed 2 sets of timestamps: the time of the events as recorded by the monitoring system, and the time at which specific notations had been entered into the incident report itself. The notations describing Karen's intervention had been entered at 4:17 in the morning at Moore, then 4 hours after the events they described, and the sequencing had been adjusted in ways inconsistent with the monitoring record. The events appeared in the written report to have occurred in a different order than they had actually occurred. Mercer was asked directly whether he had made modifications to the incident report after the fact. He said he had made clarifying edits to ensure the document reflected his clinical perspective, that department chiefs retained editorial discretion over incident documentation within their scope of authority, and that his intention had been to protect the hospital from validating an unauthorized procedure by allowing an incomplete account to stand as the official record. The board let him finish without interruption. Karen had not planned to say what she said next. She had prepared a clinical summary, a review of the emergency exception standards that governed privilege application in life-threatening scenarios, and a brief statement about patient outcomes. She set those notes aside and spoke without them. She told the board that she had spent the 3 days since the incident trying to identify what she could have done differently, not procedurally, but in the specific moments when Mercer had overruled her warning in front of his residents. She said she had looked for the version of events where his response made clinical sense and had not been able to find it. And she said that once she stopped looking for it, the alternative became clear. Mercer had not overruled her because he believed she was wrong. He had overruled her because she was new, because she had arrived from outside his framework of legitimate medicine, and because the idea that she might be right about something he had missed in front of 4 people he supervised was more than his sense of the institutional order could tolerate. She said that a patient had nearly died for that reason. She said she wanted the board to be honest with themselves about what they were actually deciding, not whether a rule had been broken, but whether the rule had been enforced in service of patients or in service of hierarchy. The board recessed for 40 minutes. When they returned, the chair read the findings in full. The emergency exception doctrine, as codified in St. Gabriel's clinical bylaws, permitted a credentialed physician to perform a procedure outside their formally approved scope when 3 conditions were met. The patient faced an imminent and irreversible threat to life. No physician with the appropriate privileges was available in the necessary time frame, and the intervening physician possessed demonstrated training and experience in the procedure performed. The board found that all 3 conditions had been satisfied on the night in question, and that the audio and hemodynamic records confirmed that Karen's intervention had occurred after the patient had entered cardiac arrest and after all other available treatment options had been exhausted. The complaint against her was dismissed in its entirety. Her surgical and endovascular privileges at St. Gabriel were approved with immediate effect. Mercer was relieved of his position as Chief of Emergency Medicine effective the same day, on the basis of 3 findings: that he had disregarded a specific clinical warning from a qualified colleague, that he had subsequently altered an official medical document in a manner inconsistent with accurate record-keeping, and that his conduct had demonstrated a pattern of prioritizing institutional authority over patient safety. The board referred the matter of the document alteration to the State Medical Licensing Board for independent investigation. He was suspended with pay pending that review. General Rourke visited the surgical intensive care unit that afternoon. He found Karen in the corridor outside Vance's room and told her, in the brief, direct manner of someone delivering a summary, that Vance was alert and oriented, that his renal function was intact, that the vascular surgery team had confirmed bilateral distal pulses in both lower extremities, and that his neurological exam showed no deficits. He said that Vance's consulting work was being transitioned to a colleague, and that the relevant parties had been informed. He did not elaborate. Karen did not ask. The sentence had been offered as a closing of an open question, and she received it as such. Rourke shook her hand and left with the same economy of movement with which he had arrived. 3 days later, Keene found her in the trauma bay, charting after a shift, and told her the department had a structural problem it had been trying to solve for 2 years, that the hospital's mass casualty and critical trauma response protocols were inconsistent across disciplines, that nursing, emergency medicine, and surgery operated from different training frameworks that produced coordination failures under high-volume conditions. He asked if she would be willing to take on the directorship of a new integrated trauma response program. She said she would on one condition: that the program's training model evaluate clinical input on the basis of evidence rather than rank, and that this principle be written into the program's governing charter, rather than expressed as an aspiration. Keene said he would have the language drafted before the end of the week. She signed the appointment paperwork on a Tuesday morning, in the same building where 11 days earlier a hospital administrator had asked for her badge. Mercer was clearing his office when she passed the door on her way to the attending lounge. He stepped into the hallway with the air of a man who had been rehearsing something and had decided he would rather say it than not. He told her she should understand what had actually happened, that a general had appeared at the right moment and given her a story, and that without that story the outcome would have been different. Karen looked at him and said what was true. The general knew my name. He didn't place the balloon. He didn't bring that man's heart back. Colonel Vance is alive because I knew what to do while you were still giving orders. Mercer had no answer to that, not because the words were cutting, though they were, but because they were simply accurate, and accuracy had been the problem between them from the beginning. She walked back to the trauma bay for her next shift. The residents who had been in Bay 4 that night moved aside without being asked. Leah looked up from the workstation, pulled the top chart from the intake stack, and held it out with both hands. "Dr. Lawson," she said, not the way you say a title, the way you say something you mean. Karen took the chart and looked up at the assignment board, where the names of waiting patients were listed against fluorescent white. The board was full. It was always full. The emergencies did not wait for the politics to resolve themselves, and the politics had never mattered to the emergencies. What mattered was who was standing in the room when the door opened, and whether they knew what to do. At Kandahar, they had given that a name. Here, she didn't need one. A doctor isn't measured by where they trained, what title they hold, or how many powerful people know their name. They're measured by what they do when death walks into the room and everyone else stands frozen. Karen knew that. She had always known it. And now so does everyone at St. Gabriel. If this story stayed with you, share it with someone who needs to hear it, and subscribe to Mystic Chapters if you haven't already. There are more stories like this one waiting for you every single week.